Hello and welcome everyone. Today is the part 2 of the journal review for the last 2 months, that is July and August 2023. The first study is propafenone versus amiodarone in septic shock patients with arrhythmias. This compared the two drugs in acute onset supraventricular arrhythmia in septic shock. It was a two-center study with 209 patients. Patients were randomized and the primary outcome was sinus rhythm at 24 hours, time to first sinus rhythm, the arrhythmia recurrence. So at 24 hours, sinus rhythm was there in 72.8% of propafenone group and 67.3 of amiodarone group. Time to sinus arrhythmia was 3.7 hours with propafenone and 7.3 hours with amiodarone. Recurrence was 52% with propafenone and 76% with amiodarone. So propafenone offers faster cardioversion and fewer arrhythmia recurrence. And there was no significant difference in the rhythm control at 24 hours. So in terms of efficacy, propafenone was better. The only subgroup where amiodarone has better results was with patients who had dilated left atrium. Now, propafenone, as we all know, is a class 1C arrhythmic drug. Its mechanism of action, it blocks the sodium channels, inhibits the potassium channels, and has a beta blocking activity. So it is given at a dose of 150 milligram every 8 hourly initial dose. Maintenance can go up to 300 milligrams every 8 hourly. Maximum we can give 900 milligrams per day. Intravenous, if you are giving, you can give 1 to 3 milligram per kg over 10 minutes with a 1 to 4 milligram per minute continuous infusion for maintenance. The next study is midline catheters compared with peripheral intravenous catheters for therapy of 4 days or longer in pediatric patients. This is a randomized controlled trial. In this, they looked whether the two catheters had better efficacy and cost effectiveness. It was a pragmatic randomized trial done from July 2020 to May 2022 in a quaternary pediatric center in Brisbane, Australia. The inclusion was age group between 1 to 18 years and they were randomized 1:1. The primary outcome was all cause device failure. So the key findings are lower device failure in the midline catheter group 16.1% versus peripheral, which was 46.2%. Fewer insertion attempts and increased dwell time with the midline catheters. Additionally, additional vascular access was needed rarely with the midline group. Now, the cost factor, the patient satisfaction as well as parent satisfaction was better with the midline catheters with a lower healthcare cost, that is as much as less than 150 Australian dollars per person was spent if you use midline catheters. So if you conclude, the midline catheter should be prioritized in patients requiring long-term peripheral compatibility to reduce device failure and the associated cost with it. The next is the blood pressure management after endovascular therapy for acute ischemic stroke. This is the BEST 2 trial. In this, they targeted various systolic pressures after a successful endovascular therapy. It was a randomized open label phase 2 trial in 120 patients. It was run in US in stroke centers from 2020 to 2022. They randomized to the three SBP targets, that is less than 140, less than 160 and less than 180. So they followed up the infarct volume, which was 36 plus minus 12 hours, and they weighted the Rankin score at 90 plus minus 14 days. So as far as the outcome, there was no significant difference in any of the outcomes they were looking for. And the prediction of success with these lower BP targets in future are also very less. So currently the guidelines are recommending less than 180, and that is what appears to be giving decent benefit in these patients. The next is early intra-atrial venting versus conventional treatment in left ventricular decompression during left veno-atrial ECMO. This is the EVOLVE ECMO trial. In this, they compared the conventional versus early decompression of the left ventricle, which was done by percutaneous transseptal left atrial cannulation. Now, in this, they randomized 30 patients into the two groups. However, they did not find any significant difference in terms of the winning rate and in terms of survival to discharge. The pulmonary congestion score improved only in the early LV uploading group at 48 hours. That was the only benefit they got by early venting. Overall, the outcomes were not very favorable to the intervention. So we can conclude that this did not improve the outcomes. and the study does not support the application of this way of producing a left ventricular decompensation. Now, the next is CPAP versus HFNO for acute hypoxemic respiratory failure and RCT. This will compare CPAP versus HFNC in high risk intubation patients with acute ischemic stroke, acute hypoxemic respiratory failure. This was a multi-centered open-label parallel RCT. It had 85 patients randomly assigned to two groups. The endpoint was time to meet pre-specified criteria for intubation within 28 days. In this, they found giving CPAP had only 28.9%, whereas 42.6% met the intubation criteria with the HFNC. So CPAP definitely reduced the risk of intubation, and there was no significant difference in terms of intubation rates in hospital or 28-day mortality or the ventilator-free days. And though better oxygenation was seen with the CPAP group. So CPAP definitely is more effective than HFNC in reducing the risk of meeting intubation criteria in acute hypoxemic respiratory failure. Now, the timing of complete revascularization in STEMI patient with multi-vessel disease. So, when should we do the revascularization? Now, to determine the optimal time for complete revascularization of the non-culprit lesions in patients with STEMI with multi-vessel coronary artery disease. Now, this was an international open-label randomized non-inferiority trial with 37 sites across the Europe. They had 418 patients with immediate PCI and 422 patients with staged PCI. And the primary outcome was a composite death with any cause, non-fatal myocardial infarction, stroke, unplanned ischemia-driven revascular or hospitalization for heart failure at 1 year. So in terms of primary outcome, the immediate group had 8.5%, while the stage group has 16.3%. This was statistically significant. Non-fatal MI was 2% in the immediate and 5.3% in the staged. Unplanned revascularization was 4.1 in the immediate and 9.3 in the staged. They had the similar death, stroke, and hospitalization risks. Severe adverse effects were 104 with immediate and 148 with stage. So, immediate multivessel PCI was non-inferior to the stage multivessel PCI in hemodynamically stable STEMI patients with multivessel disease at 1 year. The next is the use of ECLS in infarct-related cardiogenic shock. Now, this study was done to look for the impact of ECLS on mortality in patients with acute myocardial infarction who are having cardiogenic shock. It was a multi-center trial, and it divided the patient into two groups, ECLS group and the control group. Out of this, 420 were randomized, and the death at any cause at 30 days was taken as the primary outcome. So if we come to the primary outcome, it was 47.8% with the ECLS group and 49% in the control group, statistically insignificant. Median duration of ventilation 7 days in the ECLS, 5 days in the control. Moderate or severe bleeding 23.4% in the ECLS, 9.6% in the control. Peripheral vascular complication 11% with ECLS and 3.8% in control group. So, in conclusion, ECLS therapy did not reduce the risk of 30-day mortality in acute myocardial infarction patients complicated by cardiogenic shock, and it also has the increased risk of complications. The next is complete versus culprit only PCI in older MI patients, the FIRE trial. Now, it assesses the benefit of complete revascularization versus culprit only vessel vascularization in older patients, that is more than 75, with MI and multivessel disease. They randomized 1,445 patients with a median age of 80 years. And the primary outcome was composite death, MI, stroke, and revascularization at 1 year. So, in terms of primary outcome, it was 15.7% in complete versus 21% in culprit only group. This was statistically significant. Death was 8.9% in complete and 13.5% in culprit only. This was not statistically significant. Safety outcomes were similar in both the groups. So, in conclusion, older patients with MI and multivessel disease, physiology guided complete revascularization reduced the risk of composite death, MI, stroke, and ischemia driven revascularization at 1 year. Now, veno-arterial ECMO versus standard care in cardiogenic shock, the EuroShock trial. In this, they evaluated the early use of veno-arterial ECMO to improve outcome in persistent cardiogenic shock in post-primary percutaneous PCI. Now, this was a multicentric pan-Europe study, 35 patients, and they looked at 30-day all-cause mortality. Secondary outcome was 12-month all-cause mortality, 12-month composite outcomes. Now, in terms of primary outcome, it was that is 30-day mortality. It was 43.8% with the VA ECMO group, 61.1% in the standard care group, and the 1-year mortality was 51% with ECMO and 81.5% with standard care. Regarding the complications, it was 21% 0.4% with ECMO versus 0%, and the complication with the more complications were seen with the VA ECMO than with the standard care group. So, in conclusion, the trial was inconclusive due to the limited patient recruitment, which was impacted by the COVID-19 pandemic. And the study demonstrated the feasibility but also the challenges of conducting such a trial. So, future large trials may be needed because it had only 35 patients to know what the differences were. The next is the algorithmic approach to ventilator withdrawal at the end of life. They evaluated the effectiveness of an algorithmic based approach for greater patient respiratory comfort during ventilator withdrawal, assessing difference in opioid versus benzodiazepine use, identifying factors associated with the duration of survival. It was a stepped wedge cluster randomized trial at 5 sites. Used usual care data was 120 patients, and in the algorithm group there were 48 patients. They looked at the respiratory distress observation scale for patients' comfort, and the parenteral morphine and lorazepam equivalents were calculated. All patients in the usual care arm underwent one-step ventilator cessation, while in algorithm they had a step approach. So 58% in the algorithm arm were weaned over an average of 18 plus minus 27 minutes. Significantly less respiratory distress was seen in the intervention arm, where an algorithm based approach was done. More opioids and benzodiazepines were given in the control arm. Now, the algorithm approach was effective in ensuring that the patient's respiratory comfort was maintained. More medication was used in the usual care, suggesting that less may be needed when the distress is objectively measured and treatment is initiated promptly. The next is ultrasound guided arterial catheterization in pediatric patients. In this, they look for catheterization of the radial, dorsalis pedis, and the posterior tibial arteries by ultrasound. This was an RCT in less than 3 years group, and the first attempt to successful cannulation was the primary outcome. They included 270, that is 19 each group. The first attempt success was 82% with radial, 76% with dorsalis pedis, and 81% with posterior tibial. Overall success rate was 94% with radial, 93% with dorsalis pedis, and posterior tibial was 91%. Independent predictors of first attempt success was the diameter of the artery and the presence of a trisomy 21. No significant difference were seen in the three groups. So, dorsalis pedis and posterior tibial are viable alternatives in pediatric groups where we want to put an arterial line. The next is the ultrasound guided infraclavicular versus femoral artery catheterization. This is again a RCT which compared the two groups. It was a prospective investigator initiated non inferiority trial done in Poland, and they randomized 110 patients. They looked for the cannulation success, and they found 96% cannulation success in both the groups. So the overall axillary artery cannulation was non-inferior to femoral artery cannulation and with no significant safety issues. The next is a DETECT randomized trial, that is finger cuff versus intermittent oscillometry arterial pressure monitoring. Now, evaluation of the continuous finger cuff arterial pressure monitoring can reduce the hypotension within 15 minutes after anesthesia induction and during non-cardiac surgery compared to intermittent oscillometric monitoring. Now, this was a single center RCT with 242 non-cardiac surgical patients, and the two groups I have already told. The primary outcome was the area under the map of 65 within 15 minutes after anesthesia induction. The median area under map of 65 was 7 millimeters of mercury in the finger cuff, and whereas it was 19 in the oscillometry, which was statistically significant. The secondary outcome was the time weight average of map less than 68%, 65 millimeters of mercury during the surgery, and it was 0.04 in finger cuff and zero point 0.4 in oscillometry, which was also statistically significant. So, continuous finger cuff arterial pressure monitoring effectively reduces the hypotension within 15 minutes after anesthesia induction and during non-cardiac surgeries compared to intermittent oscillometric monitoring. The next is surgical fixing of the rib versus non-operative management in severe chest wall trauma. The It was a randomized trial where the radiographic frail segment without clinical fail, more than 5% objective consecutive rib fractures or any rib fracture with bicortical displacement, and in this they did the surgical stabilization. The primary outcome was hospital length of stay, and the secondary outcomes with length of stay in ICU, ventilator days, and opioid use. 84 patients were randomized, 42 in the each group. The hospital length of stay was greater in the surgical group, and the length of stay on the ICU and ventilator was similar. At 1 year, the surgical group had greater mobility, greater impairment in mobility, and self-care dimension in terms of the quality of life. So, the surgical stabilization increases the length of stay without improving the quality of life at 6 years. So, majority of the patients reported moderate to extreme pain and impairment in physical activity at 1 month, regardless of the treatment approach that was given. The next is post-hospital recovery trajectory of family members of COVID-19 survivors. This was a study which was done in the Spain and UK, and they looked at a lot of thematic contents. In this, they looked at the 19 family members across various international sites. So the four themes were mainly identified, that is changing relationship patterns and the carer burden, the family health and trauma, the social support required and the network for it, the differences in the lived experiences. Now, Spanish participants more frequently discussed regarding religion as a form of support for post recovery days. Now, the conclusion was family members face a lot of challenges in the post hospital discharge, need for specific support mechanisms, possibly including peer support networks to meet the ongoing needs should be met. The next is treatment directives and mechanical ventilation in elderly ICU patients. It was a study which was a prospective study in 142 ICUs with regions, and in this they evaluated the characteristic difference to limit the treatment and discontinue invasive mechanical ventilation in elderly group and very elderly group. And in this they evaluated 788 patients, out of which 586 were elderly, 202 were very elderly. Very elderly had more withholding orders, especially for CPR and dialysis after ICU admission, which was 67%, 33% versus 21% compared to the elderly group. Orders to withhold intubation were sooner in very elderly, again compared to the elderly. Similar rates of direct extubation, direct tracheostomy, and initiation of SPT between the two groups were seen. Higher hospital mortality was obviously seen with the very elderly group. Direct tracheostomy and initial failed SPT associated with worse outcomes. So, very elderly patients had more orders to withhold treatment, higher hospital mortality, similar ICU outcomes, and ventilation discontinuation strategies between the two groups were seen. Significant regional differences were seen in terms of withholding and withdrawal practices. The next is sepsis associated acute kidney injury in ICU, a multicentric trial. This was done to describe the epidemiology of sepsis associated AKI based on the ADQI definition. It was a retrospective cohort study in 12 ICUs from 2015 to 2021, examined the incidence of patient characteristics, timing, trajectory, treatment, and outcomes. 84,528 admissions were studied, and out of this, 13,451 met sepsis associated AKI criteria. The incidence peaked at 18% in 2021. The median time to sepsis associated AKI was 1 day from ICU admission. At diagnosis, 54% had stage 1 AKI, mostly due to low urine output, which was 65%. Lower renal replacement therapy requirements in patient diagnosed with urine output alone was 2.8% versus 18% versus 50%. Now, overall mortality with sepsis associated AKI was 18%. In conclusion, sepsis associated AKI occurs in 1 in 6 ICU patients and is diagnosed on day 1. Significant morbidity and mortality risks are seen. Patients mostly admitted from home via the emergency department. Most sepsis associated AKI is stage 1 and due to the low urine output. So, This is all the study that we have for you today. Please comment below if you want to elaborate on any particular study, and thank you for your patience.